talks into one, talking a little bit about endoscopic transorbital surgery. No relevant financial disclosures, but I hope that by the end of the talk to convince you guys that transorbital approaches to the skull base do have a lot of advantages for select pathology. And I think the key in adopting these in your practice is starting with the appropriate cases, building gradually, and of course multidisciplinary collaborations for the intracranial portions. So for those who aren't really familiar with transorbital endoscopic surgery, the orbit as a corridor is not new. It's been used for lobotomy for many years and other things, but with the advent of the endoscope, it's really moved to the forefront of neurosurgery as a primary route for a lot of skull-based pathology. And if you look at some of the covers of the neurosurgery journals over the last few years, this is really front of mind. So if these techniques have not come to your institutions quite yet, they will be soon. Just to get a sense of the audience, how many of you guys are using endoscopes in your practice, whether for DCR or orbit surgery? You guys are using endoscopes a little bit. Okay. So these are sort of natural evolution, and as orbital surgeons, we certainly already understand when we're doing decompression and tumor surgery the intimate relationship between the anterior cranial fossa, the middle cranial fossa, and the orbit. This is something we encounter every single day. And to remove the bone from these locations to access pathology on the other side, this is really standard stuff that we're doing in all of our thyroid decompression surgeries. Certainly some people get more wide dural exposure than others. I think the addition of the endoscope really allows you to very easily and safely do this. So we'll just talk a little bit about the technique for incorporating in your practice. Our basic setup is the surgeon stands on the operative side, and we typically utilize a scope holder, either an assistant or actually a mechanical scope holder that I'll show you, and an assistant to retract the orbit. The equipment is then positioned to the side with the anesthesia across on the other side. The endoscope is helpful in these cases to minimize your dependence on having two assistants and to allow you to operate with just one assistant, so that you can kind of see here, I don't know if this will project, but the surgeon's left hand is holding the suction, the right hand is holding the drill, one assistant is retracting the orbital contents, and then the endoscope holder is showing the view, and you can kind of see here there's a monitor directly across from the surgeon, and then another monitor at the foot of the bed that allows the assistant to visualize what's happening during surgery. So the bone that's removed in these approaches, again, is really the same bone that you're often removing in lateral orbital wall decompression, and I'll talk a little bit about that later, but essentially you're removing the bone between the supraorbital fissure and the infraorbital fissure, and then you're exposing this structure that we don't often encounter in oculoplastic surgery, which is the meningoorbital band. That's sort of an extension between the dura through the supraorbital fissure to the periorbita. When that's divided, essentially all the temporal lobe can be reflected, and you have wonderful access to pathology in the middle cranial fossa, the lateral cavernous sinus, the Meckel's cave moving further back, and even in the petrous apex. So this really is a powerful and direct approach to a lot of skull-based pathology that's otherwise challenging to reach and requires significant retraction. So I think when you're kind of moving into these, it's important to build a team, collaborate with your neurosurgery colleagues, and I think start with appropriate cases. So this was the first case that my neurosurgeon that I work with, Ted Schwartz, and I took on together when I was a fellow. This was a 79-year-old woman who had basically a recurrent glioblastoma and needed a biopsy, a diagnostic biopsy. And you can see the red arrow kind of pointing to the pathology in the middle cranial fossa and sort of extending into the lateral orbit. And so it was something that was readily accessible. It was did not require a lot of deep dissection. It was sort of a nice chip shot for our first case to do together. So the approach is pretty standard, but the difference is, again, we're using the endoscope here to really allow us to have direct visualization. The bone is removed in the greater wing of the sphenoid, and a biopsy can be collected. So this was a pretty straightforward case, allowed us to get a diagnostic biopsy while avoiding a craniotomy. And closure is standard. And you can see pretty minimal morbidity at 6 days, looks just about like any other orbital decompression surgery would. Much better, certainly, for an 80-year-old woman than going through a craniotomy. So kind of beyond some of these easier first cases, we started moving into extradural cases. So this was a challenging case of a dermoid cyst, essentially, that was causing a compressive optic neuropathy of the cranial nerve 3. She presented with ptosis and headache. Again, this would be sort of at the skull base, a difficult one to sort of access. You can see the relationship to the carotid artery, and would require a lot of brain retraction to essentially access this, whereas the orbit provides a relatively direct pathway. So this, again, we've now kind of moved past, and we're having to remove the meningoorbital band and reflect the temporal lobe. Excuse me, I'll play the video over again. But this sort of, let's see if I can skip through. Play the video. So dividing the meningoorbital band is kind of the key step that I think is one of the initial challenges when you're learning this approach. So again, just an eyelid crease incision, divide the orbicularis, subperiosteal dissection, and then we're drilling the bone between the greater wing of the sphenoid, basically between the superior and inferior orbital fissure. Once we start to get dural exposure, you can switch to curettes or kerricins to help, just like you might in a lateral decompression, to open up the bone in that area and really get wide dural exposure. And you can start to see the brain there, that's the temporal lobe. And then once that bone is removed and the sagittal crest, which is the lateral aspect of the supraorbital fissure, is exposed, you can see the meningoorbital band there, which is divided. Once that meningoorbital band is removed, you really can widely reflect the temporal lobe, and you can see the drainage of the cyst there and marsupializing the cyst. So that kind of shows the basic steps of surgery nicely. And this is our patient, again, month 3, fairly limited morbidity compared to the morbidity for a young patient to go through a craniotomy, and she had resolution of all of her symptoms. So this same corridor provides a really direct pathway to pathology in these multiple locations. We've done intradural, extradural. I think the key, again, is starting small, getting comfortable with the equipment and getting comfortable with the approach, and having a good, close working relationship with your neurosurgeon. And most recently, we've kind of progressed to bigger intradural cases, whether it's intradural meningioma, intradural gliomas, but it's really the approach is the same. But here's an example of a temporal lobe meningioma, again, right at the skull base, would require a significant craniotomy and a lot of retraction. And this is approached, again, just from an orbital surgery side, just like a lateral wall decompression, subperiosteal dissection, exposing the superior and inferior orbital fissures, drilling that greater wing of sphenoid to expose the temporal lobe, and then approaching this laterally. This one is a little different in that we're actually going to open the dura, but you'll see that the technique of sort of drilling hand over hand, I think the endoscopic visualization really gives you high magnification, nice resolution that allows you, once you get down to dura, to really feel comfortable about safely removing all of that bone without risking injury to the dura. And then, shortly here, this is removing the sagittal crest, which again is that lateral aspect. We're in the right orbit here, so we're looking at the lateral aspect of the superior orbital fissure. Once it gets to the dura, of course, this is typically when I'll turn the case over to neurosurgery. You can see our neurosurgeon here opening the dura with endoscopic scissors, and shortly he'll use a curette to essentially remove that intradural component. And you can kind of see the tumor starting to present itself there, but sort of using a hand-over-hand endoscopic technique to remove the tumor. So this is certainly in the domain of neurosurgery, but the approach, I think, for all of you is well within your skill set who do any high volume of orbital surgery. For dural reconstruction here, our neurosurgeon used an inlay-onlay graft, which is basically a sandwich of alloderm, one on the inside, one on the outside. We use Tisseel. You can kind of see it sliding one leaflet inside the dura, one leaflet outside the dura. We'll use Tisseel and typically abdominal fat to reconstruct that osteotomy, and then just a layered closure sort of in standard fashion, which I can skip for sake of time. But you can see this patient on day 0, really fairly minimal morbidity for what was essentially an intradural resection of a brain tumor, and at month 3, really minimal morbidity at all relative to a craniotomy. So I think these are powerful techniques. I think these are coming to your institutions. Our experience, we've now done about 30 cases. We published kind of our first 20 cases in the literature last year, and we published a few of our results. The primary pathology or primary side effects, I suppose, or morbidity we've seen has mostly been hyposthesia, probably from the frontotemporal and frontozygomatic nerves, temporozygomatic nerves. We did have one Terson's-like syndrome, probably from impaired venous outflow, venous congestion during the retraction. And we had one in the significant case of canal hyperostosis and a sphenoid wing meningioma. We took a patient who was count fingers pre-op or hand motion pre-op to NLP afterwards. Those have been cases, I think, no matter what the approach, that would have been challenging to treat. But other than that, we really haven't had significant enophthalmos. We haven't had significant vision changes. We have not had strabismus. And if you compare kind of the early outcomes versus the late outcomes, we do see patients who have a little bit of ptosis kind of in the early postoperative period. Certainly everybody has eyelid swelling. But if you look at kind of our 3 to 6 to 12-month follow-up, these complication rates are very rare. And as an orbital surgeon, kind of in these cases, I have to sort of frame my experience more on the neurosurgery side of things. So if you look at some of these, this is an orbitozygomatic approach, which would otherwise be used to approach the pathology in these locations. And you're looking at diplopia rates somewhere in the 25% range. So I think, as an orbital surgeon, we don't want any cases of diplopia after surgery or any cases of transient ptosis after surgery. But compared to the alternative options, I think these are fairly minimally invasive. I think in the interest of time, I'll skip through these, but this was the Terson syndrome we had from this different intradural meningioma, probably from retraction morbidity on the optic nerve and venous outflow congestion. We had one CSF leak that was just treated with packing, over-sewing the wound, and they put a lumbar drain. Since this case, this one was one we reconstructed the lateral wall with a PDS sheet. Since then, we've switched to doing that abdominal fat graft that I use, and we have not had a CSF leak since. And then this was the patient I mentioned who had kind of significant intradural canalicular disease that did go from sort of having this very suppressed visual field that you saw here preoperatively to being NLP afterwards. So I think, again, no matter what technique was used, this would be a challenging case, but this was one unfortunate outcome from our series and probably our worst outcome. So I think my perspective currently is that this is definitely here to stay. This is something that all neurosurgeons are going to be doing, and I do think that as ophthalmologists, we have to have a role. We we have to help guide the decision making. I think we have the best perspective to sort of guide some of the intraoperative decision making with surgery, and certainly following outcomes and capturing risks and complications and things like that. So I think this movement's going to continue. Whether or not we choose to participate, I think will be up to us at our individual institutions, but this is front of mind in the neurosurgery community right now. So I think it is important for us to take a leading role, especially as orbital surgeons who have this expertise, and allow our neurosurgery colleagues to do these procedures safely. So I don't want to hold up, I know we kind of got a late start here, but just this technique that I learned from working with the neurosurgeons and doing the endoscope-assisted approaches can actually be translated to lateral wall decompression for thyroid eye disease. I shortened this top significantly, but in my practice now, this is sort of how I handle bone in the lateral orbital wall. The green section I still will do with loops. I think it's so anterior, it's awkward to use the endoscope, but for the deeper bone, and particularly the areas of thin bone overlying the dura, I think the endoscope gives you that kind of magnification, illumination, and really that nice deep depth of focus to do this aggressively and safely. So again, kind of in the right hand, as I showed in that still shot earlier, holding usually a 4mm drill to start and then a 3mm drill at the apex. I like an angle drill to give you a clear view, and it's typically a self-irrigating drill. So then in the left hand, you're holding the suction, which allows you to clear your field of view. The assistant is then holding the endoscope, or you can use a scope holder. And then just kind of one time showing a little bit of the drilling in the lateral wall. So same approach as you would use in one of these transorbital cases. This is the last video, and then we can move on. Exposing the superior and inferior fissures just like you would in any other decompression. And I found using the scope, I feel much more comfortable getting a very deep decompression with wide dural exposure. And again, sort of using the suction in the left hand to clear your field, the drill to get dural exposure, and then if you so choose, you can switch to the Kerrisons for additional bone removal. So, and this just shows you how powerful this can be. I think this would be a difficult case to do if you weren't using endoscopic visualization and might require a craniotomy. And then for standard thyroid eye disease cases, I think it's just a powerful tool that allows you to be a little safer, but also more aggressive in your deep lateral wall decompression. So if you're interested in learning these techniques, I do help run 2 courses. One is at Cornell with my neurosurgery colleagues, and another is at Columbia with my ENT colleagues. They both have sort of virtual options for participation, or if you're interested in coming to New York and learning some of these techniques in hands-on fashion,